It's a pleasure to have you join me today. My name is Dr. Chris Barrett. I am a podiatrist. I'm the director of two outpatient wound care clinics for the Crozier Keystone Health System, just outside of Philadelphia, Pennsylvania. Let's take a look at this difficult case, okay, your plantar diabetic foot ulcer, and kind of how we're going to approach that using a disposable device and kind of how I kind of collaborated with my physicians to kind of get this device in use to kind of get a chronic wound, move it on to healing. So our patient is a 55-year-old, kind of a typical diabetic, Charcot neuroarthropathy, rocker bottom foot, diabetic, history of stroke, so peripheral vascular disease, PAD, kind of working together. Thankfully, had very good circulation. Studies were excellent. Good flow right into the toes, so he had a good toe brachial index, so we know he had good pulsatile flow. He did not have osteomyelitis. We looked at radiographs, and he did not have a plantar exostosis bone that would have kind of prevented us from ever healing the wound. So it kind of seemed like everything was there for us to get this wound healed. He was referred by another podiatrist to me and to our center, someone I knew, to get total contact CASID. And we know that that's, again, if I'm going to say one thing, the most important part of this is on a plantar diabetic wound, a neuropathic wound, it's offloading, okay? Before you do anything, if you're not going to properly offload, then you're not going to have any success, no matter whether it's negative pressure wound therapy or any advanced therapy or AWD, you're not going to get the wound healed. So thankfully, he was referred to get really the gold standard, but at least proper offloading to get this wound healed, and that's total contact casting. So our patient presented with the wound that looked like this. Okay, so this wound had been open for a couple of months. So the problem is, we know with a diabetic, we're looking at, the goal is 4-week healing, 50% at 4 weeks. We know the evidence shows that that's kind of going to predict 12-week healing. So we had a wound that was already stuck, that was chronic, and was improperly offloaded, as you can see. So we have a chronic stuck wound in a diabetic who we know from evidence that diabetic patients, diabetics with a foot wound, have a mortality rate that's approaching 50%, a 5-year mortality rate. So this is, this is like cancer, okay, even worse than cancer. So very, very important that we do the right thing for this patient. And number one is going to be offloading. So we have a chronic wound that needs offloading. Unfortunately, the patient refused, did not want to really affect his quality of life, and decided, I don't want the cast, even though we recommended it. Now, again, another physician was treating this patient. So this is these slides. When I came in to help with the total contact cast, the patient said, not interested. Okay. 14 days later, he came in for a follow-up. And what do you see? So you see an increase in hyperkeratotic tissue and callus, peri-wound callus. So there's a tremendous amount of pressure around this wound. And if this continues, we know that this relatively small wound is going to expand, and then we know what's going to happen after that. This patient's going to end up developing a bone infection, going to need surgical intervention, his limb is at risk. So this is the message, okay, that we're trying to relate to this patient. He's refusing casting, okay, just does not want the hassle of cast. So here we go. Day 42, the wound is looking much worse. So at this point, I actually sat down with the patient. I think this is very important, that you have to have, a frank conversation about the dangers of allowing this kind of presentation, this wound chronicity, to continue. So I told the patient, I said, this is what's going to happen. This is what the evidence, okay, this is what we know is going to likely happen. This wound is going to progress to bone infection, to osteomyelitis, which is going to be, very, very difficult to treat in a midfoot area, okay? And the risk of amputation goes up. I like to talk to my patients about the 5-year mortality rate and the importance, how, this wound is kind of like cancer and worse than some cancers. And it's amazing how having that one-on-one conversation really had this patient rethink the idea of offloading. And the importance of the total contact cast. Remember, the shoe, the patient was wearing a surgical shoe, which is typically what's used as an offloading device, and as you can see, is very ineffective. But we need to lock that ankle joint, prevent strain, prevent shear, okay, and unload that plantar aspect of the foot, and put 30 to 40% of that weight savings up on the cone. Okay, so whether you're using a rigid total contact cast or a full length cam walker with a proper insole, but locking that ankle at 90 degrees is the most important part of this. That's why those two devices are really the best options these patients have for offloading. the patient agreed to start total contact casting. So I was involved now at this point in putting the total contact cast on, and really, again, that collaboration with the other podiatrist, kind of helping them make choices. But we really kind of told the patient that if you look at studies, 6 to 8 weeks, we should have really, really good progress with this wound using a total contact cast. And we did initially. As you can see, we have less callus, we have a clean wound bed, reduced in size. But as I said, we had applied 6 casts, but from cast 4 to 6, that 2-week period, we saw no change in the wound size and the appearance of the wound. So what's the thought process? So again, I was asked to kind of collaborate at this point, and my thought process was biofilm. Okay, it has to be bacterial contamination. We can't really get into a discussion about the nature of biofilm. Very resistant to topical interventions. Okay, so our topicals are not working. So what do we need to do? Let's get more aggressive. As I showed you, this is following sharp debridement, but look at the reduction in callus. So we know we're doing the proper offloading. It's the wound bed. It's the surface of the wound that's our problem. Aggressive sharp debridement, tissue nip the entire edge to kind of make a chronic wound into an acute wound. Okay, so now we're going to start again. How do we treat this wound from the acute point? So my recommendation was, let's add negative pressure wound therapy. Let's add a collagen-based graft, okay, and using the ring for good adhesion. And we're going to continue our total contact casting, our offloading. Okay, so what I'm kind of showing you is a stepwise kind of application. The ring, very important for the plantar wound, plantar aspect of the foot, because again, it's a difficult area. You definitely don't want to have any kind of leakage after you put a cast on. So that ensures you get a really good quality seal. Okay, also important, and I'll show you later, is how you orient the bridge dressing, okay, and the direction so that it's pointing in the right direction when you, apply that hydrocolloid. Okay, and then I used a 4x8 piece of foam because we know that the bridge doesn't quite reach the top of the cast, and we want to kind of protect that tubing. Okay, it's very soft, but we want to protect the skin from any damage. And a simple 4x8 piece of foam works perfectly in a total contact cast, reaches right to the top of the cast. And that's how I did it. And this was 8 days after starting that protocol. So 2 weeks, 4 casts, which was 2 casts per week. I used 3 snap dressings, disposable snap dressings, and we had the wound completely epithelialized. So if we're going to talk about some tips or some tricks for getting a good outcome with snap, not getting frustrated, because it is a pretty simple dressing. Number one, as I told you at the beginning of our little talk here, friction and shear kills negative pressure wound therapy. I don't care if you're using a vac or a disposable device. You have to use the proper offloading device to prevent the foot from moving, from shearing, from sliding, which is going to doom your dressing, and you're going to get a leak. And you know that you don't want to place your dressing and very quickly have the patient calling you that there's a leak under the cast. Okay, so that's why it's so important that, number one, you do the right offloading device. And I mentioned total contact cast or a cam boot, full length, one or the other are really your best options. I showed you the case with the secure ring, the snap hydrocolloid secure ring. Very, very important on the bottom of the foot. I always use it because, again, using that with the hydrocolloid contact, you're going to have an excellent seal, and it's going to reduce the chance that you have any leakage and that patient's going to be calling you. Orienting the bridge dressing. And I think this is very important. I don't have a model or someone to show this on, but I'll give you an idea. So, on the foot, okay, so when you place this dressing, okay, you want to make sure that this tubing is going to end up going up the leg. Okay, so you want the direction to be going up the leg. What you don't want is when you place this dressing on the bottom of the foot, that now it's going off to the side. Okay, the tubing is facing at a 90-degree angle, and it's not going up the leg, okay, which is going to be very, very difficult for you to kind of get this tubing routed in the right orientation. So super important that before you put that dressing and stick it to the ring, you kind of make sure you have your orientation going, pointing up because you're going to get some interesting curvature. But again, it's foam backed, and as long as it's lying flat against the skin, okay, you can kind of route it in the right direction. No wrinkles that would cause any pressure areas. Okay, so again, very important that before you peel and stick, make sure you know exactly how your orientation is going to be with the dressing. And I showed you that I had exposed the tubing is not going to make it all the way up to the top of the cast, okay, or the end of the bridge dressing. So there's that roughly 8-inch, okay, area where I take a 4x8 piece of foam, okay. What I like about this is, number one, you have a silicone backing, okay, which is a little tacky. So when you place it against the skin, it's not going to harm the skin, but it's also not going to move, okay. And then you can rest, okay, you can rest your tubing, okay, against the foam, okay, and route it, as I showed you, right up to the top of the cast, okay, and connect it to your canister. So again, these are, it's just a very simple trick, very inexpensive piece of foam, but it really, really protects you and allows you to kind of complete the dressing. If you have a high draining wound, a lot of exudate, you have a 150 cc canister option. Okay, larger canister. If you're going to extend your time to change the cast to a week, okay, you can manage a lot more exudate. I like in the beginning, twice weekly TCC applications. You take the cast off after 3 or 4 days, see how the patient's doing, how much exudate, how's the wound doing, okay? And maybe after the second week, if you're comfortable that one cast application a week, maybe a large canister or maybe the small canister if there's not a lot of exudate, if that's going to work for you, that's ideal, then you can kind of continue in that direction. But I think it's more prudent to kind of be careful in the first week or two with SNAP and with the TCC or your offloading device, okay? I wish I could share more, but we're kind of out of time, but thank you for joining me. Enjoyed our discussion.